Thanks everyone for joining us.
Thank you, Daisha. Welcome everyone to Hopkins and also to our remote audience. Thank you for joining us today for our surgical illustration presentations by the class of 2023. I'm Corey Sandone. I'm the director of the Department of Artists Applied to Medicine and the course director for surgical illustration. In this course, our second-year students have each observed and sketched multiple procedures, and they will present two today. First, they will show you a series of pencil sketches describing the operative steps. Then they will show you their final artwork for one or more of the figures. And in a related assignment, the students depicted the same procedure for a lay audience, and you will see these as well today. The majority of the work you will see is designed for an audience of surgeons, residents, and fellows. Faculty in our department evaluate the student work on the accuracy, clarity, and effectiveness of the images to visually communicate the steps and concept of these operative procedures. We also encourage students to use cutaway views, transparency, and other illustrative devices to add information that could not be captured in a photo or a surgical video. I thank everyone who helped the students achieve success in this course, our faculty and staff and artists applied to medicine, the surgeons, residents, and fellows who welcomed the students to observe their cases, then reviewed the sketches and further explained the procedures, and all the operating room staff who facilitated our students in the ORs the past 4 months. This opportunity and your participation makes surgical illustration a strength of our graduate program. Welcome to alumni, family, and friends of the students who are viewing remotely. The presentation is being recorded and will be available on YouTube after this event. We appreciate you joining us today to see the really spectacular work the students have created. And our first presenter is Gilbert Chen.
Thank you, Corey. All right. Hello, everyone. My name is Gilbert Chen. For the first surgical illustration, I observed a cochlear implant procedure. The cochlear implant device consists of external and internal components. Surgically implanting the electrode array into the cochlea allows patients to hear better. In Figure 1, a C-shaped incision was made behind the right ear. Figure 2 shows the spatial relationship between the masculinization region and the cochlea in the temporal bone. Figure 3, the periosteum was open and the temporal bone was exposed. Figure 4, a masculinization was performed. On the right side of the figure, the round window was exposed and then open. I choose this figure to fully illustrate for journal publication. Figure 5, a bone bed was created for holding the device using the surgical drill. Figure 6, finally, the surgeon places the receiver behind the ear and an electrode array into the cochlea. Now I'm open for questions and comments. Yes.
Very difficult surgery to depict because of the subtle differences in the bone and showing the depth. And I think you did a very nice job of making decisions about what to leave in the view what to edit out, and you were able to keep it clean and understandable without oversimplifying. So I think you did a very nice job in your artistic editing.
Appreciate it. Thank you, David. Yes.
In this figure, even though at this point, the surgeon would know where they are, but if this is going to be a standalone piece in your portfolio, I think it's a good idea just to help orient the viewer.
Thank you. All right, thanks for all the comments and feedback. Now I will move on. For the second surgical illustration, I observed an endoscopic endonasal resection of the pituitary adenoma. This surgery used nostril as a natural corridor for access to a tumor. Figure 1, the middle and inferior turbinates were all fractured. In figure 2, the inferior 1/3 of the superior turbinate were resected bilaterally to gain better surgical access to a skull base. The plan of this procedure to go through the sphenoid sinus and then remove the lesion, in this case, pituitary adenoma. Next, a nasoseptal flap was created for reconstruction at the end of this procedure. Figure 4, a posterior septectomy was performed to allow surgeon to reach the midline of the skull base. And we can see here and here, the nasoseptal flap was tucked into the nasopharynx. Figure 5, a sphenoidotomy was performed to open the sphenoid sinus and expose the sella. You can see here. Figure 5b, we see the sphenoid sinus opened and the sella exposed. In figure 6, the sella surface was removed using the surgical drill. In figure 7 and 8 shows the removal of the tumor in both endoscopic view and sagittal section. I painted these two figures in Photoshop and Procreate. While illustrating this piece, I pay additional attention to designing lighting and the color to lead the reader's eye throughout the artwork. Finally, the nasoseptal flap or free graft was placed into the sphenoid defect for reconstruction, depending on the procedure. Now I'm open for comments and questions again. Yes, Tim.
Final image. You effectively used flat color throughout your sketches, and the sketches are very well done. And it directs the viewer to the area that you want to communicate as being important. And in this particular image, you let the dark background accent the colors that you have in the center, which drives us to look at the area of action. Well done.
Thank you, Tim.
We have a comment from the YouTube audience. Scott Rollins, who is a professor at Arcadia University in Pennsylvania, said he assumes your line work was created digitally, but I like the hand-drawn gestural quality of your lines.
Thank you. Actually, the line work is both. Like in the beginning of the stage, I create all my sketch just on paper using pencil. And then later on, I move into Procreate to clean up the line work a little bit. Yeah.
This is a really minor comment. So I really love your layout, but where you have your signatures, it can be easily erased and also kind of causes a little bit of tension just being right there in the eye. So I would suggest maybe moving it in between your inset and the main image in that little triangle that you have there. Just a minor suggestion.
That's a really good suggestion. Thank you.
Mm-hmm.
I just wanted to compliment all the work you've done on the neuroanatomy since the last time we met. It looks really nice. Like all the proportions look wonderful, and the lighting inside of the sphenoid sinus is really successful too.
Thank you very much. Thanks for all the comment and feedback. Now let me introduce my classmate, Libby.
Thank you, Gilbert. Hello, everyone. I'm Libby Seidel. Today, I'll be discussing two procedures I observed, the first being a total thyroidectomy. First, I'll show an overview of the procedure with an illustration I created for lay audience. At the top is an overview of the anatomy. Then we see how the thyroid gland is surgically removed, separating it from its blood supply. Then we see the underlying anatomy after the procedure with the thyroid removed and parathyroid glands preserved. A thyroidectomy is typically performed due to thyroid cancer, enlargement, or medical conditions such as an overactive thyroid. I'll now walk through my sketches of the case I observed in more detail. Figure 1A shows the supine position of the patient with underlying anatomy shown. 1B shows a low collar transverse skin crease incision about 2 centimeters from the sternal notch. 1C shows dissection of fascia in the avascular plane. Next, the strap muscles are incised and spread laterally to expose the thyroid gland. In figure 3, the thyroid is elevated and medially rotated to identify the middle thyroid vein, which is divided with a ligature close to the thyroid gland. Next, Joel's triangle is identified, medially by the central line, laterally by the superior thyroid vessels, and superiorly by the strap muscles. Within this space, the external laryngeal nerve is identified and avoided. Then, the superior thyroid artery and vein are identified and divided close to the thyroid gland. Next, the inferior thyroid artery is identified and divided. The procedure is then repeated on the other lobe of the gland, repeating the same divisions of vasculature. Then the thyroid gland is lifted from the tracheal bed, Barry's ligament is divided, and the thyroid gland is removed. Finally, figure 8 shows the closure of the wound with a simple continuous suture of the infrahyoid muscles and running horizontal mattress to approximate the skin. For my illustration, I chose to render steps 3, 5, and an anatomical overview of the thyroid gland and its blood supply. Here's the final illustration. I created it using Photoshop, and it is intended for journal publication. Figure A shows where the vessels will be ligated using dashed line, while figures B and C give a surgical view of the steps. I now welcome any questions or comments. David?
I like your balance of conventional color and realism. I think that you have used color very wisely to clearly show the difference between the vessels and the subtle differences in the tissue. And I think just works very well. Well done.
Thank you, David.
In looking at your surgical sketches, I want to compliment you on your tissue reaction and line weight and draftsmanship. And I hope that in the future, as you probably are doing now and continue to do so, you'll use those sketches as under painting or under line work for whatever color work you're going to create.
Yeah. Thanks, Tim.
Just a quick comment to tell you that I think that the way that you've used really clear instructional color, these read really well as slides. In fact, like if you divided the top figure and the two bottom, they would work beautifully. I know it's for journal, but it's just very clear.
Thank you, Jenny.
Yes, we have a comment from the YouTube audience. Michael Leonard suggests Libby to move the signature off of the retractor.
Okay. Thanks, Michael.
Another comment, this one is from Scott Rollins, also again from Arcadia University in Pennsylvania. I don't know if your original image was intended for the general public or a journal, but the palette you chose, mostly warm hues, oranges and browns, with touches of blue, is very effective.
Thank you so much. Thanks, everyone. For my second surgery, I observed a laparoscopic bilateral salpingectomy. This procedure is typically performed to reduce risk of ovarian cancer or treat an ectopic pregnancy. First, a 12mm trocar with a 10mm scope is placed in the umbilicus region, and two 5mm trocars are placed in the right and left lower quadrants. The patient is then positioned in dorsal lithotomy steep Trendelenburg. In figure 2, the uterine tube is retracted at the ampulla region with a ligature. In figure 3, the mesosalpinx is divided close to the uterine tube toward the uterus. In figure 4, the uterine tube is divided close to the uterus and removed. I decided to illustrate step 3, the division of the mesosalpinx, as my final piece. Here's the final illustration. I used a dashed line to show where division occurs, implying the procedure occurs on both sides. I also showed underlying anatomy of the uterine vessels, ovarian vessels, and the ureter within the mesometrium and suspensory ligament. I painted this piece in Photoshop and created the instruments in Cinema 4D and incorporated them into the piece by painting over the 3D assets. All right. Thank you. I welcome questions and comments. Jeff?
The light reflection on the instruments is. Oh, sorry. The light reflection on the instruments is so pretty. Did you set up some lights in C4D or did you paint it in Photoshop after you brought it out?
That's a good question. I did set up lights in C4D, but then I definitely amplified them and added like the specular lights and everything in Photoshop with paint.
I appreciate how you illustrated the peritoneum here, the sort of the folding of the peritoneum as there's upward traction on the tube. I think that that's the illustration of the peritoneum and how it responds to surgical manipulation is not something that is well illustrated in the medical literature. And I think it's really nicely done here.
Thank you so much.
So kind of piggybacking on that recent statement, I think you've done a marvelous job of pulling us into the interior here with your lighting and a sense of atmosphere and being inside. So use of color, directed light, shadows, well done.
Thanks, Tim.
Yes, we have two comments from the YouTube audience, and they are one from Michael Leonard, great proportions of the uterus and surrounding anatomy, very nice. And the next one is from Donnie Bliss, faculty at Johns Hopkins, great use of 3D to save effort. And Jennifer Wayne, a graduate from 2022. Libby, your 3D instruments blend so nicely with your painterly style.
Thanks, everyone. Appreciate it.
Oh, no.
Can you talk about your decision to label it as a uterine tube as opposed to a fallopian tube?
Sure. Yeah. The question was, why did I choose to label it as uterine tube instead of fallopian tube? And Fallopian is like an eponym name, and I decided to opt for the descriptive name, but they both mean the same thing. You're welcome.
I also want to compliment you on the peritoneum representation, and as the surgeon for this procedure, it looks very familiar, which is good. And it also shows a lot of the relevant anatomy that would be relevant to this surgery, and thinking of using this for maybe teaching a resident how to do the surgery. I think it would be a really, really useful illustration for that. So thank you.
Thank you. And thanks for the help on the project as well.
Tube.
Okay, noted. Well, thanks everyone. I'd now like to welcome my classmate, Jian.
Hello, I'm Jiyoung Oh, and I'll be presenting my surgical illustrations today. For my first surgical illustration, I observed a nerve transfer between the ulnar nerve and the median nerve. My first illustration is for patient education for lay audience members and is an introduction to my first surgical illustration. Damage to the median nerve can cause loss of motor function in the thumb. By joining branches of the median and ulnar nerve through a nerve transfer surgery, motor function can be restored. In this case, the abductor digiti minimi branch of the ulnar nerve was divided and used to reinnervate the thumb. I'll be describing the procedure in which the median and ulnar nerves are coapted. And the surgery was performed through a diagonal incision on the palmar side of the patient's hand. Next, the transverse carpal ligament was divided to allow access to the branches. Once each branch was located, vessel loops were placed around them. The branches were transposed medially and coapted in a tension-free fashion using 8/0 nylon epidural sutures. Here is my final illustration. I created it in Photoshop and the format is made for journal publication. Figure 4A shows the anatomy of the nerve branches with an inset showing the transverse carpal ligament division. Figure 5 shows the divided thenar motor branch, and figure 6 depicts the joint branches. In this slide, the illustrations have been rearranged in the format for presentation. I now welcome questions and comments.
It's really nice to see the piece and the new layout, Jiyoung. I really appreciate all the work you put into it during our class critique. It looks great. One thing I might consider is just a slower fade out for the fingers and the wrist. They sort of abruptly go off into space. So I might just soften that a little bit so it doesn't catch your eye so much.
Thank you, Lydia.
I know, it's great.
Yeah, this is very nice. Again, I think you have a really pleasing palette. It's subtle, but it is clear. It's easy to understand. One thing I would recommend is maybe push your shadows between the skin and the subcutaneous edge and the anatomy. Just a little bit more accenting. It looks like it's kind of fuzzing out a little bit in 4B, and maybe you observed something in surgery that I'm not thinking about, but I think a sharper use of accents where you have pooled blood and it will add to the depth, and I think it will be more effective.
Thank you, David.
Overall, very, very nice.
Thank you. For my second surgical illustration, I observed a hysterectomy and bilateral salpingectomy and oophorectomy. During the case, the surgeon also demonstrated the steps of a salpingectomy that could be a standalone procedure to reduce the chances of ovarian cancer. A camera port was inserted through the umbilicus. 16 millimeters to the patient's right, a Da Vinci Progress forceps were inserted. Monopolar scissors were inserted 8 millimeters right of the umbilicus, and an 8 millimeter incision was made for the air seal trocar. And the patient was in steep Trendelenburg position throughout the procedure. In step 2A, the setup of the salpingectomy method was demonstrated. And in step 2B, an incision was made in the mesosalpinx close to the fallopian tubes, starting from the tubo-ovarian ligaments to preserve the blood supply in the broad ligament. And in a salpingectomy procedure, only the fallopian tubes are removed on both sides. After demonstrating the salpingectomy, we return to the total hysterectomy method. And the first step is to use cautery to divide the suspensory ligament and the ovarian artery to cut off blood supply to the uterus and ovaries. On this slide, we see that the uterus is retracted to the right. And by cauterizing through the vesicouterine peritoneum, the bladder was separated from the uterus, and the uterine vessels were cauterized as well. Vesicouterine peritoneum was further cauterized to expose the colpotomy ring and to detach the cervix. And the uterus, the fallopian tubes, the ovaries, and the cervix were removed in an endobag through the vagina. The vaginal closure was performed using a continuous V-lock barb suture. My final illustration depicts steps 2A and 2B, which includes the anatomy of the salpingectomy method with an inset explaining the pathway and the location of the fallopian tube resection. And the steps are repeated on the other side of the uterus. I now welcome any questions and comments.
Oh, Jiyoung, this is so great. And I am just so grateful to you for doing this, because I think that relationship that you show between the tubo-ovarian ligament and the suspensory ligament is not something that I think exists in the medical literature. And you know, we're getting ready here. Hopkins is sort of the epicenter for launching a public health campaign to get the word out about the fallopian tube being the origin of, 80% of ovarian cancer. And so as we begin to create knowledge translation about performing this specific procedure, which can be very simple and low risk if done, right, this relationship between these two ligaments, that needs narration and communication around it. I think you did such a good job showing how that tubo-ovarian ligament is in front of that suspensory ligament, and how where you have that scissors coming across that tubo-ovarian ligament and sparing that suspensory ligament posterolaterally is so great, and how like you're hugging the tube and you're preserving that anastomosis between those big vessels in the mesosalpinx, that anastomose between that suspensory ligament vessels, and then on the other side the utero ovarian ligament. It may be helpful, I don't know, may get too wordy, but to also label the utero-ovarian ligament, where you have it sort of next to the uterus there, where those vessels are going.
Thank you, Dr. Sen.
I can't top that. I want to compliment you again, taking us inside the body and creating this atmosphere, and your tissue reaction, your color coding, the palette is all very beautiful. And congratulations, it's well done.
Thank you, Tim.
Yeah, really beautiful, Jiyoung. The palette, again, is fantastic. It's subtle, but not too subtle. I can see what I need to see. The fold of the tissue, although I know it a lot less well than the surgeons for sure, is something that I'm, not familiar with, and certainly haven't seen a lot of. My one comment, this is for slide, correct?
I'm sorry.
This is for slide?
Yes.
Yeah. So the one thing I would recommend is your dashed line where you show blood supply for fallopian tube cutoff. I think should definitely be one of your dark magenta flesh colors, or even black maybe. It just doesn't stand out well from back here, and it's so important.
Okay. Thank you, David.
highlights of all of the tissue residing inside. That's really, it's not overwhelming. It's perfect. Well done.
Thank you, Tim.
Donnie Bliss, a faculty member at Hopkins, said similarly to Gabby's earlier comment, a bit more sharp contrast around points of action would help draw the viewer's eye. Also from Jennifer Wang, Ji Young, I love your use of transparency with the vessels through the ovary and ligaments.
Thank you, Donnie. Jennifer. Thank you, everyone. And the next presentation will be by my classmate, Lily.
All right. Hi, everyone. Thank you so much for coming today. My name is Lily Armstrong Davies, and I will be presenting 2 surgeries today, beginning with a robot-assisted radical prostatectomy. A prostatectomy is a surgery used to treat prostate cancer. The prostate is positioned between the penis and the bladder, and the urethra travels through it. The prostate is removed during surgery. The urethra is then reconnected to the bladder. I'll now cover the steps of the surgery from beginning till end. The patient was placed in a supine low lithotomy position and the table in Trendelenburg position. An 8mm robotic camera was placed at the umbilicus. 3 8mm robotic trocars and 2 additional trocars were placed under direct supervision. An incision was made in the posterior peritoneum to access the vas deferens and seminal vesicles. The vas deferens was divided on both sides. Next, an incision was made in the anterior peritoneum. The bladder was separated from the abdominal wall and retracted posteriorly. Superior to the prostate, the dorsal venous complex was ligated and divided. The puboprostatic ligaments, structures that connect the prostate to the pubis, were divided on both sides. Finally, the anterior bladder neck was divided. The Foley catheter was then retracted and the posterior bladder neck was divided. At this point in the procedure, the seminal vesicles and vas deferens were revealed at the posterior aspect of the prostate. Seminal vesicles and vas deferens were dissected and retracted superiorly. Denonvier's fascia, located between the prostate and the rectum, was dissected to release the inferior aspect of the prostate. Next, the prostate, seminal vesicles, and vas deferens were retracted laterally, and branches of the prostatic artery, called prostatic pedicles, were clipped and divided. Branches of neurovascular bundles traveling to the prostate provide blood supply and innervation. These branches were clipped and divided on both sides, which preserves the innervation to the penis. This was done in an antegrade technique, traveling in the same direction as blood flow. After the neurovascular bundles were released, the prostate was divided from the urethra, and the prostate, seminal vesicles, and vas deferens were removed. Lastly, the cut end of the urethra was reconnected to the bladder with simple continuous barbed sutures. I chose to fully develop slide 7, the antegrade release of bilateral neurovascular bundles, a technique that helps preserve quality of life for patients post-surgery. I painted this piece in Photoshop and included a lateral schematic on the top left corner to simplify the relevant anatomy and orient the viewer in space. The dotted arrow depicts the antegrade direction of neurovascular bundle release. Thank you for your attention, and I open the floor to any questions. Thank you for your attention.
The neurovascular bundles look really cool. How do they look in real life? And how did you decide how to depict them?
This is a very educational view of it. In reality, it's actually quite hard to see them because they're completely covered in fascia. And the camera view would be right up against those where the instruments are. So this is actually quite a bit of a step back. Yeah, so you can't really see them at all.
Combining that with Jeff's question, you've done a wonderful job of delineating the various structures within that neurovascular bundle, and the instruments themselves are driving the viewer right to the point of action. And another example of a well-executed color palette and tissue reaction.
Thank you so much, Tim.
Mention something, especially for the non-medical illustrators in the audience, the decisions that you made. Notice how Lily has let the shaft of the instruments fade out in the periphery, and the contrast around the tissue and the neurovascular bundle and the vessels is more so right in the center where she wants the viewer to look. And so Lily made some really nice but very subtle decisions that really direct our eye, on top of what Tim was saying, but just with use of color and contrast. So very nicely done.
Thank you so much.
Lily, it's a beautiful piece, and I'm amazed at how well you hid your signature. Where is it? It's I should say it's a piece worthy of your signature.
Thank you, Anne. It's on my printout, I swear.
Okay, very good.
Awesome. For surgery 2, I illustrated a partial neurectomy of the deep ulnar nerve, a procedure used to reduce spasticity in the hand. I begin with a sketch of the relevant anatomy, including the course of the ulnar nerve, its branching into deep and superficial nerves, and their anatomical relationship to the hypothenar muscles. First, the deep ulnar nerve is dissected and elevated with vessel loops. The nerve is stimulated with a nerve stimulator that causes muscle movement in the hand. This is done to confirm that the right nerve was dissected. Next, the nerve is partially divided with scissors. Figure 3B depicts the extent of the partial neurectomy, followed by the repair using simple interrupted suture pattern. I chose to develop steps 2 and 3A, labeled here as B and C. Based on feedback from the surgeon, an additional step showing the release of fascia compressing the deep ulnar nerve was added in step A. I painted this piece in Photoshop. Thank you again, and I welcome any more questions or comments.
Hi, good. Hi, good. Lily, this is it's sort of a treat for me to have missed the previous critiques on this piece, because I get to see it for the first time, so it's really fresh. Your sketches are beautiful. The tone, the tissue reactions really effective. In this particular view, you said it's for slide?
Yes, this is for slide.
It's great. The labels read really well. My only suggestion is the fat is quite saturated, and I know it is in real life, but for instructional purposes, I might tone the saturation of it down just a little bit so that the nerve pops out a little bit more in contrast, because that's sort of your main focus.
Thank you so much, Jen.
Yeah.
Lily, I have a question in A. Did the surgeon, after spreading the scissors to free up the nerve under the fascia, did they turn the scissors then to make the cut? I would assume, right?
Yeah, they would use 2 different pairs of scissors. So one would elevate and then the next one would cut. Yeah, we tried sketches of that, and it was a little bit confusing with both of them in yeah, but it might be nice to add another step showing that second cut. Yeah.
What would be nice in A, even if you choose to just leave the spreading step and the dissection free, is if you could position the scissors or maybe spread the tines just enough to be able to detect the nerve a little bit better back there. I can see it, but just by moving left or right, you might be able to show some of the negative space on either side and just give the viewer a little bit more information.
Yeah, that's a great idea. Great. Thank you so much, everybody. It is my pleasure to introduce my classmate, Miranda.
Hello, I'm Miranda Stano. The first surgery that I will be discussing today is a robotic total hysterectomy. In this example, the ovaries will be preserved. To provide a concise overview, I will begin by showing a patient education piece that I created to explain this procedure to a lay audience. During a robotic total hysterectomy, the uterus and cervix are removed. On the left, the first illustration details sites for robotic ports as well as the location of the uterus. The right side illustrations show before and after views. The upper illustration acquaints the viewer with individual structures of the uterus and allows them to appreciate their relationships with surrounding organs. The lower illustration demonstrates what the body looks like after the uterus, cervix, and uterine tubes, also called fallopian tubes, are removed. Now I will go into more detail while describing the individual steps of this surgery. A camera port is placed in the umbilicus. The patient is then placed in a steep Trendelenburg position, and additional laparoscopic ports are added under direct visualization. Here's the location of the camera port as well as its direction. And here we view the patient's right pelvis, where the right ovary and the round ligament can be seen. The round ligament is sealed and divided, allowing access to the retroperitoneal space. The right ureter is identified as it enters the pelvis. In step 3, the right fallopian tube is carefully detached from the ovary, preserving the ovarian vessels. In step 4, the right utero-ovarian ligament is sealed and divided. Following this, the healthy right ovary is moved out of the operative field. Next, attention is turned to the broad ligament. On each side, the posterior leaf of the broad ligament is divided to the level of the uterus, mobilizing the ureter to protect it from injury. 6A shows the anterior leaf of the broad ligament being opened to create the vesico-uterine reflection. In 6B, this opening is extended to mobilize the reflection distally. Steps 2 through 6 are then repeated on the left side. The right uterine vessels are skeletonized and divided. Division closer to the source of the uterine artery preserves the vaginal branch and prevents unnecessary blood loss. This step is then repeated on the left side. Successive pedicles through the cardinal ligament are created parallel to the cervix and medial to each previous pedicle until the level of the external os is reached. Using the cervical cup of the uterine manipulator as a guide, a colpotomy is created circumferentially. The uterus, cervix, and fallopian tubes are delivered through the vagina. Finally, the vaginal cuff is reapproximated with V-lock suture. All instruments are then removed, the robotic system is undocked, and incisions are closed. I decided to fully paint step 7 in this procedure. Corrections were made to the initial sketch, helping to emphasize the course and branching of the uterine vessels. An inset, 7B, showing a posterior view of the uterus was added to better indicate that the uterine vessels are divided and the vaginal branches are preserved. Thank you for your attention. I will now open this up for questions.
I just, I've seen this image before, and it's just beautiful. But on the previous image, actually, I don't know if I had seen it before, but just the way that you illustrated the removal of the entire resection,
It was really, really cool to see that. Actually, you don't normally get to see that kind of a view. And so I just want to compliment you on your previous sketches as well, because those are certainly just beautiful assets that you might be able to use in the future.
Thank you so much, Jenny.
A continuation of Jenny's comment. If you go back to that slide where you show the whole specimen, yeah, you would never see that in a photograph. You just arrange the specimen so that we can see all of it. And we can also see where it's being removed from the operative view. So it's great.
Thank you so much, Corey.
I'm going to say thank you for showing how the ovary, when it remains, is still attached to the sidewall. I can't comment on the illustration techniques, but from a gynecologist perspective, I get questions so often from patients of, well, what happens to my ovary? Is it just floating in space? Because so many diagrams don't show how its main connections are actually to the sidewall and not to the uterus. So I think that this helps demonstrate that.
Wonderful, thank you.
Compliments you on your vignetting coming from the exterior into the interior of the area of action, the subtle soft color and soft highlights, and then reserving the most of the tone and the highlight in the area of action, and the uterine vessels as they're snaking and streaming along there. Really well done.
Thank you, Tim.
Hi, I just wanted to compliment your work. I think your color palette is really lovely and I admire your sketches. And I was gonna also say for your final rendering for this particular step, I really like that you included that alternate view of which vessels are retained after the procedure. I think that could be really helpful to anybody. So yeah, great work.
Thanks so much. All right, I will continue. The second surgery I observed was a total thyroidectomy. This procedure was performed through an open incision. Steps were repeated on both sides to entirely remove the thyroid gland. In step 1, above the sternal notch, a 5-centimeter incision is created, reaching the level of the anterior jugular veins. In step 2, the median raphe is identified and divided. The sternohyoid muscle is separated from the sternothyroid, and in turn, the sternothyroid is separated from the thyroid gland. In step 3, the pyramidal lobe and Delphian lymph nodes are removed. Step 4 shows the division of the superior pole vessels. Barry's ligament is divided, taking care to preserve the superior and inferior parathyroid glands and to not injure the recurrent laryngeal nerve. All steps are repeated on the patient's right side. Remaining attachments are divided and the thyroid gland is removed. Steps 6 and 7 show incision closure with the reapproximation of the strap muscles and the skin. Of the steps described, I selected number 5 for full development. An inset, 5A, was added, which allows the viewer to appreciate the surgical positioning of the superior parathyroid gland before preservation. 5B combines 2 closely related actions. First, the division of Barry's ligament is shown. Second, in order to ensure that the often difficult to see inferior parathyroid gland is preserved, a Freer elevator is used to sweep the posterior portion of the thyroid back into the body. Pertinent anatomical structures, including the recurrent laryngeal nerve, the inferior thyroid artery, and parathyroid glands are labeled. The superior parathyroid gland is also depicted preserved. I will now answer any questions.
This is a beautiful piece, and I wanted to just compliment you both on this piece and your last one, Miranda, just on your capturing of the value range of what you're trying to show, the tissue, the whole piece, because as the first years heard recently and know, if you have the value down, you can play with the hue, and you really have that down, especially in the last piece actually, but also in this one. You control your values, and as a result, you really capture the form beautifully. I especially like the division of Barry's ligament. I think a really well depicted area is something that you could show a sculptor and give them a lump of clay and have them sculpt it. People could sculpt that from your drawing, and that's a really wonderful thing to pull off with color and tone. So very nicely done.
Thank you so much, David.
I also want to compliment you on your use of accented outline in some areas in your sketch. I think it adds, especially that it's a colored line and not a dark line. It just suggests a little bit more about the form, and the lobulation and the thyroid is really well done.
Thanks.
Brenda, I think the rendering is fantastic, and you have really nice shorthand for what the glandular tissue looks like. Just a little bit of mark making in the crevices, and then the way you have subtle highlights is really effective, and it's different from the fat and the muscle, obviously. The RLN is
recurrent laryngeal nerve.
I think you might spell it out because it's such an important part. And if this is going to be a standalone in your portfolio, you have the room. You might use a hierarchy of type, having some bold and some unbold, but to distinguish which are the ones that you mostly want the viewer to, read first. But I think that one is worth spelling out.
Yeah, that's a great suggestion, and I'll add that in for my portfolio. Thank you.
So we do have a comment from the YouTube audience, Scott Rollins again, a great balance of subtle toning and crisp edges that helps to separate structures. Also, Jennifer Wang of the class of 22, the contrast you used behind the instruments create a nice sense of depth in your piece. And also Gabby from the class of 22, the sketches you've made work really well with your final piece.
Thank you so much, everyone. All right, thank you for thank you for your questions and comments. The next presenter will be my classmate, Anne. Thank you for the introduction, Miranda. Hello, everyone. My name is Anna Mai, and the first surgery I'm going to present today is a penile prosthesis implant procedure. I'd like to thank Dr. Burnett for the opportunity to observe this procedure in the OR and for all the feedback he provided. Here's an overview of the procedure that was designed for a lay audience. The implant is a device that is placed inside the penis to help men with erectile dysfunction achieve an erection. The procedure is often performed after other treatments for erectile dysfunction have failed. First, a urinary catheter is inserted to drain the bladder. A 5 to 6 centimeter incision is made, exposing the dartos fascia seen here in 1B. The dartos fascia is then cleared using blunt dissection to isolate the corpora body. In 3A, 2 corporotomy incisions are made. Stay sutures are then placed vertically on each side of the 2 corporotomies, resulting in 4 total sutures. In 3B, the tissue is retracted with these sutures, and electrocautery is used to create the corporotomy. Next, the distal and proximal corporal lengths are measured using a dilation tool. The next step is pre-placing sutures that will be used at the end of the procedure to close the corporotomies. The suture is placed approximately 3/4 centimeters above the proximal apex of the corporotomy.
The step is then repeated on the other side. To prepare the inflatable cylinder for insertion, the suture on the distal side of the cylinder is loaded onto the keep needle. The needle is then inserted onto the furlough insertion tool. The tool is then inserted into the corpus cavernosum via the corporotomy, perforating the glans penis. The keep needle is then used to pull the inflatable cylinder into position. This step is then repeated on the other side. Here is the 3-piece implant device, depending on the corporal length, which was measured previously. Rear tips extenders may be used for a custom fit. In 7B, both cylinders are now fitted inside the corpora. Next, the pre-placed suture are then used to close both corporotomies. Another instrument can be used to cinch down the cylinder and protect them. The stay sutures are then tied in a box pattern seen here in 8B. To create a space for the reservoir, the index finger is used to palpate the external inguinal ring. Once identified, the finger is used to blunt dissect towards the floor of the external inguinal ring, perforate through the transversalis fascia. In 10, the scrotum is inverted and electrocautery is used to create the dartos pouch, where the pump will be placed. Here is the complete placement of the implant device. After the reservoir is filled up with a saline solution, it is then linked to the pump using a connector. And lastly, the dartos fascia is closed using a simple running suture, and the skin incision is then closed using a simple interrupted suture pattern. This page is meant for a journal layout. For my illustration, I chose to render step 5 of this procedure, which shows the insertion of the pre-placed suture. And this is the final illustration. I render the corpora with more details compared to the surrounding skin to draw attention to the main action. I now welcome any questions or comments. Yes, David.
And I just want to say this is a really nice illustration, the whole series of sketches. 2 things I want to compliment you on is you have really kept your shadowed tissue lively. So you've kept the saturation high, which I think really adds to the life of the piece and kind of the reality of the tissue. And also, so often you see surgical pieces where you wonder whether the illustrator has actually been in surgery and seen surgery. But your sketches make it very clear because you have shown nuances of tissue and the way it's being retracted and how it's reacting to retraction that convinces me that you observed this at least once and you captured that. And so it adds to the credibility of the piece as well.
It's a great compliment. Thank you so much. All right, if there's no more questions, I will move on. Okay, the second surgery I'm going to present is a robotic inguinal hernia repair. I'd like to thank Dr. Manukian for the opportunity to observe this case and for all her feedback throughout the process. To set the stage, this is a right indirect hernia procedure. The location of the defect superior to the inguinal ligament is shown here in red. The patient is in supine position with both arms tucked, and 3 8mm ports are placed as shown here. For an overview of the inguinal hernia anatomy, here's a view of the anterior abdominal wall. This is the patient's right side. The hernia defect can be seen to the right of the inferior epigastric vessels and above the inguinal ligament. I've indicated here the triangle of pain and the triangle of doom. Disruption of structures within these areas can cause complications during the procedure. A transverse peritoneal incision is made in 2 stages, taking care to avoid the inferior epigastric vessels. It is made approximately 6 cm above the hernia defect. The peritoneal flap is extended medially from the medial umbilical ligament and laterally towards the anterior superior iliac spine. Then these two peritoneum windows are connected. The hernia sac is then identified and dissected free from surrounding structures. Next, a self-fixating mesh is used to cover the hernia defect, and the peritoneum is then closed. Here are the steps I chose to render. This is designed as a presentation slide that can be shown during a lecture. I put these two images together so the audience could visualize the hernia defect outside and inside of the peritoneal flap. I used transparency in both images to show the important underlying structures. In 3C, I draw attention to the hernia sac by using a brighter and more saturated color. In addition, the background structures are less detailed and duller in color to create depth and to separate them from the main action. Thanks for your attention, and I now welcome any questions or comments. Tim.
I can't provide a better description than what you did, what you just said. This is a difficult area to understand the various layers and all the structures that pass through it. So great explanation and great illustration.
Thank you so much, Tim.
I actually have a question.
Yes.
For all of you, really. As a non-medical illustrator, it's fascinating to me that you are able to sit through a surgery and capture these moments. I'd like to know a little bit about how you do that. Is it just fast sketching, or do you go back, like, how do you do that? I would imagine if I was to do it, I'd have to take pictures and then go back and analyze that. So I want to hear.
Yes, so for our class in particular, we spend a couple hours, a lot of hours in the OR, observing the surgery and taking down sketches. And these sketches that we did in the OR, they're more like taking notes, but in drawings. And then later on, we also do more, further research, reading research articles, to learn about the different structures and the important. And we also have to think about which structures are important to leave in and which structures to leave out to, eliminate the cognitive load for the audience.
Thanks, that's great. And I think it's fascinating that you're able to capture the actions so specifically, and how everything moves. It's just, anyway, it's great.
Thank you so much.
Yeah.
The other thing is that as first year students, you've taken the anatomy course with the med students, and you've become very familiar and understand all the structures and where they're placed and all the nuance of vessels, nerves, everything like that. So, and I know you all each prepare the night before, the days before, by reviewing that anatomy again of that particular area in order to be able to illustrate it effectively.
And quickly, right?
Yes, thank you, Tim.
Just so we don't think this is a love fest, it's beautiful, but I've got to throw in. No, I would encourage you, I know we talked about this at one of the critiques leading up to this, but I would encourage you to maybe build a model with kneaded eraser clay and get that flap on 3C and light it and really look at the shadow, because I'm not quite convinced by the shadow as we go to the apex of the opening. I think it would come a little bit closer and converge with the point, with the apex.
Yeah, great
and then get
suggestions.
softer. It's close, but I just think that it would have a lot more impact. Everything else is just so nicely done, but that shadow just doesn't quite, it's not quite there.
Yeah, that was one of my problem area. Thank you for the suggestions. Yeah.
We have several comments from the YouTube audience, in particular, Jennifer Wang. Anne, beautiful composition. Your didactic color choices, transparencies used in your sketches have translated effectively in your final render. Also from Nick Reback of JAMA, Great work managing detail and so many structures in such a small space, very clearly explained.
Thank you so much, everyone. All right, if there's no further questions, I'd like to introduce my classmate, Courtney.
Thank you for the introduction, Anne. Good afternoon, everyone. My name is Courtney Brundle. First, we will look at my illustration series that summarizes an aortic valve replacement procedure. Here is a patient education piece that provides a snapshot of the surgery, in which a replacement valve is used to restore proper blood flow to the heart. Now for my sketches of the operative steps. A sternotomy and pericardiotomy are first performed, and this drawing shows the resulting exposure and cannulation of the heart. During cannulation, cannulas are inserted into the aorta and into the vena cava. An additional vent is inserted into the aorta to help with the onset of cardiopulmonary bypass. Once the patient's blood from the heart and lungs is diverted and rerouted outside of their body during bypass, cardioplegia, the arrest of heart movement, can begin. The aorta is clamped once the heart stops beating. Next, a transverse aortotomy is performed. Metzenbaum scissors are used to partially dissect the aorta 1 centimeter above the sinotubular junction to reveal the diseased aortic valve. Metzenbaum scissors are again used to trim away the diseased aortic valve leaflets. After the valve diameter is measured, an array of pledgeted sutures is placed around the annulus. These sutures are then sewn through the Dacron skirt of the replacement valve. And once the sutures are placed, the arm that holds the valve is pushed down, while the sutures on all sides are pulled taut, guiding the valve into place. This is referred to as a parachute method. The valve and annulus will be secured with interrupted sutures and then tied off once the valve has been seated. Overall, the sketch on this slide shows a layout meant for journal publication. Here is a painted version of it, made in Photoshop. The last slide for this series shows the plate images formatted for today's presentation. These assets were also painted using Photoshop. Thank you. I now welcome questions and comments. These assets were also painted using Photoshop. Thank you. I now welcome questions and comments.
I'll make a couple of comments. I think overall it's well drawn, well drafted. I think in this instance, the retractors are taking up a little bit of focus away from the area of action. But I think what you've done well is provide shadows around the pericardium and color coding the sutures that will attach the new valve.
Thank you, Tim. In relation to the retractors, you're talking about the rib spreaders on either side of this image here, correct? Would you suggest fading those off more? Okay. Thank you for your comments. If there are no more questions, I'll move on. Finally, my second illustration series will outline the procedure for an ovarian cystectomy of an endometrioma. First, we will begin with the trocar placement in the patient, who is placed in a lithotomy position. An 8mm camera trocar is placed several centimeters superior to the umbilicus. Robotic trocars are placed about 10 centimeters on each side from the umbilicus. And finally, a 5mm assistant trocar is placed on the patient's right. This illustration shows a pulled out camera view, so we may fully observe the uterus and a large endometrioma on the patient's left. This inset shows a cross-section of the cyst to reveal its walls and contents. Because of the old darkened menstrual blood the endometrioma retains, it is also commonly referred to as a chocolate cyst. Next is adhesiolysis, or the dissection of tissue adhesions surrounding the cyst. The endometrioma is elevated to expose the posterior side of the cyst, revealing its adhesions. These typically occur within the recto-uterine pouch. Monopolar scissors are used to dissect the ovarian adhesions and mobilize the ovary. In endometrioma cases, it is acceptable to allow the cyst to rupture during adhesiolysis as long as thorough cleaning occurs. Once the cyst fluid has been released, the suction device is used to enlarge the cyst opening and to suction away its contents. Next, grasping forceps are used to perform countertraction and traction. A clear plane of separation is carefully created between the ovarian and cyst walls. The cyst is then separated from the ovarian cortex using monopolar scissors. Thermal energy is used sparingly to preserve as much ovarian cortex as possible. Once the cyst has been completely removed, the raw edges of the ovary are brought together. They're repaired using 2 ovicral sutures with a non-hemostatic suture pattern, such as a purse string suture, to avoid cinching the ovary too tightly. After the repair, the ovary has now been reconstructed into a more normal shape, and the area is inspected to ensure that there is no additional bleeding at the surgical site. The inset in the upper left shows the state of the ovary we observed at the beginning. The final plate, created in Photoshop, underlines step 5, or the importance of avoiding damage to the surrounding ovarian blood supply during the last phase of cyst removal from the ovary. On the left, simplified insets are used to highlight the anatomy of the cyst and show before and after of drainage prior to the endometrioma's removal. Thank you all for your attention. I will now accept comments and questions. Thank you all for your attention.
I was especially taken by your sketch number 2. You want to show that again?
Yes, sketch number 2 here.
So you've laid it all out here. Here we've come over the mountain and we're looking across this vista of problems here. And it's all laid out, the adhesions and the anatomy and the positions that they're in and where we're going to go next. I mean, this is really kind of an amazing drawing right here.
Thank you so much, Tim.
And it did lead to a very nice drawing in the end. And the fact that you did use this as a reference point to get us back and forth. Well done.
Thank you very much.
Hey, Courtney.
Hi, Tanya.
This was so great. I actually really loved which sketch, I think it was 3A when you were talking about, okay, 3B. It was the
This
next
one.
one. Yes, I think that was probably my favorite sketch by far because of how dramatic it seemed. And then I also love the completely different value ranges that you had for what was leaking out of it. Quick question. I was wondering, was the other instrument that you can't really see the end of, is that the suction?
Oh, are you talking about this instrument here in the center? Yeah, that's a suction device or a suction tube. It's usually used to aspirate or suction away contents within a surgical area.
Okay, perfect. I just wanted to clarify that.
No worries. Thank you for your question.
Thank you. Great.
Thank you.
Nice job, Courtney. I'm not sure if you as the illustrator know the answer, but how functioning is the remaining ovary after the removal of this cyst for hormone production and eggs?
From what I understand, reading the literature and talking to the surgeon I worked with, Dr. Borahay, for the most part, the ovary is relatively functional once it's completely drained and cleaned thoroughly. Kind of going back to step number kind of between 6 and 7, kind of just showing just the general repair of the shape. For the most part, I believe that the ovary actually recovers quite well as long as there's no complications or infection at the site. Yeah, thank you for your question.
Michael Leonard, another medical illustrator, on image 1. Oh, yes. He really likes the fact that the first illustration shows the proportion properly with the uterus and the body.
Thank you so much. Well, thank you everyone for your attention. If there are no more questions, last but certainly not least, the next presentation will be by my classmate, Emily.
Hello, I'm Emily Simpson. My first procedure, oh, I'll take my mask off, sorry. Hello, I'm Emily Simpson. My first procedure is a mastectomy for chest masculinization. This is a gender-affirming procedure performed to flatten the chest by removing breast tissue, resulting in a more masculine appearance. The patient is placed in supine position and skin markings are applied as guides for incisions and positioning. This sketch shows the initial incision at the top of the left breast here, and a dashed line for the lower incision here. And the removal of the nipple is in progress. In 3, the incision is deepened down to the pectoralis muscle. And in 4, the breast tissue is separated from the chest. The incision is then closed, shown in figure 5. In figure 6, the nipple is prepared for reattachment and the underside is thinned. In figure 7, the chest is marked for nipple placement and an ellipse of tissue is removed. And this nipple here, after some tissue is removed, will be placed in this incision. Here we see the circle mark for placement. The nipple is positioned in the elliptical skin opening here. The nipple is sutured in place with a continuous suture that is a combination of simple running and subcuticular stitches and tacked down with interrupted sutures. This is the scene I chose to illustrate for my final artwork. This page is laid out as if it were intended for journal publication. And here is a close-up of the part I fully painted in Photoshop, showing the last step of the mastectomy for chest masculinization procedure. As a second assignment, I illustrated a reduction mammoplasty for a lay audience. This breast reduction procedure is performed to help alleviate discomfort by surgically removing breast tissue, reducing the weight of the breast. Some, but not all of the breast tissue is removed from each breast. An anchor incision shown here is commonly used to facilitate breast reconstruction after tissue removal. I welcome your feedback and questions on either of these completed illustrations now.
This is another example of a procedure where we can tell that you've been in the operating room. Just the tissue reaction that you have, the subtle skin reaction when the bottom incision is closed, and the texture of the tissue underneath the nipple is very convincing. I also think that your shadow, where the source of the shadow is where the suture is coming out right there, is really helpful in conveying depth. Congratulations.
Thank you.
Hi, Emily. This is very well done. I really like how you rendered the texture on the nipple, and as well as the tissue reaction. And also for the patient ad piece, I really love it. I think this is very informative and educational. Congratulations.
Thank you so much, Shirley.
Yeah, Emily, all nice work. I do want to comment on this piece as
Oh, this
well.
one?
Yeah, the upper right image, again, for people who maybe don't produce these type of images, just look at how informative that one image is. You know, you can put it together. It's almost like an animation because you can see with the deft use of arrows and the exposed subcutaneous tissue, it all fits together. So it's really well thought out. It's kind of it's what we do. Really nice.
Thank you, David. Okay, if there's no further questions, my next procedure is a robot-assisted cholecystectomy. This procedure involves the division of the cystic artery and duct to facilitate the removal of the gallbladder. It is commonly performed to treat gallstones. 4 ports are placed subcostally here and here, and 1 port is placed below the umbilicus here. The camera is placed in port 2 right here, pointing at the gallbladder. Sorry, the patient is placed in reverse Trendelenburg position with the table tilted to the left. Here's the operative view at the beginning of the dissection. The gallbladder and cystic duct are retracted to the left. Important structures are hidden in the connective tissue. This image shows the pertinent anatomy ghosted in. We can see the location of the cystic duct and artery here and here, which will be divided prior to the removal of the gallbladder. You can also see the location of the large gallstone right here. That was the reason for this procedure. In figure 4, dissection is continued. We can see the beginning exposure of the cystic duct. In figure 5, the critical view of safety is being obtained. This requires a window of liver to be clearly seen between the cystic artery and duct. This is necessary to prevent accidental clipping of the common bile duct or the common hepatic duct. These figures show anatomical variants that can pose a challenge to obtaining critical view of safety. Duct variants are shown on the left 2 figures here, and arterial variants are shown on the right 2 figures right here. These variants emphasize the importance of obtaining the critical view of safety as shown in the previous slide. In figure 10, once the critical view of safety is obtained, clips are applied first to the artery, then the duct. The artery is double clipped on the proximal side and single clipped distally. The same clipping pattern is used for the cystic duct. In figure 11, the cystic artery and duct are divided. Finally, the gallbladder is mobilized off the liver. We can see the cystic plate here in figure 12. Once the gallbladder is removed, the right lobe of the liver returns to its natural position, as shown in figure 13. The gallbladder is placed in an endocatch bag and removed through the periumbilical port. Here's a sketch of the steps of the procedure I chose to illustrate. My final result is painted in Photoshop. I reintroduced the depiction of the ghosted duct and arteries and used conventional color for clarity of these important structures. The gallbladder and liver are depicted in realistic colors observed during this procedure. I welcome any comments and questions now.
So it's really cool to see this piece finally in its full glory. It's beautiful. It's really, really well done. The color and the contrast reads beautifully, especially for slide. I just have a question. The instrument itself, it has that yellow, yes?
Yes, I looked up some references for this as well. Even a few different versions of them, they all had the yellow or slightly amber color.
I guess this is more of a question. I'm curious why I don't know if you know this actually, because you'd probably have to talk to the instrument company. But I wonder why it's so right? Is it for good visibility during the surgical procedure, or is it just more of a branding thing?
Yeah,
or-
that's a good question. I'm not really sure, but I'd love to look that up and maybe ask the surgeon.
The only other comment I have is if it's important, then, certainly keep it there. But if it's not, it's competing just a little bit with the action at the end of the, the tip of the instrument. So if anything, either desaturate it a little bit, or even, go with a neutral color, even, I think that would really help deliver the message that you have so beautifully drawn in the focus there. So
great, thank you.
Great job. I love seeing this in its final configuration.
Thank you, Jenny. I appreciate the feedback.
Yeah, Emily, this piece has come so far. It is really stunning. I agree with the instrument color, and because it's so close to the fat color, it looks like it's just an underpainting and just looks unfinished, even if it's very accurate. So I agree. If you can modify that, that's great. That would be great. I love the erosion of the tissue from the cautery as the hook is sweeping across in number 4. I would like to see the tissue that's being exposed with that sweep, a little bit of the duct, come up to fuller color, because it's less covered with all that tissue. And I think it would just bring home the idea of that tissue just kind of frying away. So I would push that a little further, but this is a beautiful, beautiful piece.
Great, thank you.
I'll add to that too. Yes, what's striking, I think, is the color palette that you use, and the lobe of the liver there that juts out and draws our attention, and just the inset, the way you created that as a design element. I've never seen that before. It's cool.
Great, thank you so much.
We have 2 comments from our YouTube audience. Michael Leonard, another medical illustrator, says the gallbladder seen in surgery is often seen as a blue-green. You captured the subtle shade. Excellent. Make sure your clips look closed. Also, Scott Rollins, having observed numerous cholecystectomies as a medical illustration student, it's very interesting to see this surgery performed with robotic assistance. Nice background colors.
All right, thank you both for the comments. Okay. Thank you, everyone, for your questions and comments and for joining us today. Now, we would like to make some acknowledgements. First, to the Art as Applied to Medicine faculty for their help and guidance, as well as to Daisha Balch for making this live stream event possible. Thank you to the surgeons who let us observe their work and collaborated with us on our projects, as well as to the operating room staff and nurses who accommodated us, and to the friends and family joining us today. Thank you.
Great job, everyone. Congratulations on finishing the surgical illustration course successfully. I'd invite people to join us in the lobby area. There are some refreshments and also a temporary exhibit of the illustrations on boards out there. So please join us and have an opportunity to congratulate the students. Thank you.